Great, audible. Welcome to today's session. It's the first session of the year in January, and we're off to a good start. Today's presenter is Dr. Roslyn Guki. She's a physician and endocrinologist who is a lecturer in MKU. We're going to basically discuss euglycemic DKA. Have we ever heard of euglycemic DKA? What do we know about it and how to treat it? And I don't know about you, but I can't wait to learn more from Dr. Rosie. Hi, Rosie.
Hi, Amina. Happy New Year.
Happy New Year. You're well?
Yes, I am. Thank you.
Yeah. So the floor is yours.
Okay, let me just share my screen so that we see if you can be able to see my screen. Can you see that?
Yes.
Okay, perfect.
So take us away, Dr.
Yes, so without further ado, because we're already 10 minutes into it, first I want to thank you so much for giving me such a wonderful opportunity to give a talk on behalf of KNH and University of Nairobi. Like you had mentioned, I'm a lecturer at Mount Kenya University and I do love to teach. And the reason why I coined it a misdiagnosis is I feel that quite a number of our cases of our patients are actually suffering from these conditions, and they come when it's quite far advanced, and we possibly have lost a few patients because of this particular condition. So I want to give a snapshot of some of the cases we've dealt with so that you have an idea that it's not all cut and dried. So case one is a 32-year-old patient who was diagnosed to be diabetic 1 year ago, was noted to have poor glycemic control while on combination therapy of metformin and a DPP-4, that is sitagliptin. And then hence another agent was added to the combination because they noted they're not improving, and added the new kids on the block, the SGLT2 inhibitors, empagliflozin, 10 milligrams once a day. Now he's been tolerating the medication well for about 2 months until one day when he woke up, he was quite lethargic, he's weak, and he had recently had a bout of gastroenteritis, which had left him quite dehydrated. Now, the G had stopped, but he is still feeling quite lethargic and he was not understanding what was going on. And when he woke up the next day, his relatives found he was actually confused. So they brought him to the emergency department. He was found to be confused, disoriented, lethargic, and quite dehydrated. So the casualty doctor called me and said that he's a bit hypotensive with a BP of 160, tachycardic at 100, normal temperature at 36, rest rate was okay. And on examination, it seemed essentially unremarkable. So they're even wondering, his sugar is 12, they can't quite figure out what is going on. Is it just dehydration? So they started him on normal saline, but they are worried because of the sugars of 12, he might get hypoglycemia. So I asked them to do a ketone, and surprisingly, serum ketones were about 5. So I went ahead and I asked them to do a blood gas analysis, and they found a pH of 7.1 with a bicarb of 12. So that in itself told me for sure we seem to understand what is going on. Now let's talk about another scenario, because eventually we'll talk about how we managed each of these cases. Similarly, 21-year-old now with type 1 diabetes, diagnosed 5 years back, had been on an insulin pump for the last 2 years and had been doing quite well. But then all of a sudden is admitted with complaints of weakness and inability to eat for the past 1 day. But of notice, she had not realized her insulin pump had stopped working about 2 days prior. And although she had no history of fever, nausea, vomiting, or diarrhea, or any symptoms suggestive of infective pathology, she appeared to be quite confused and lethargic. And when they examined her, other than the confusion and lethargy, she was dehydrated and there was loss of skin turgor. Now, when you look at it, look at her sugars. 4.1 is not a problem. In fact, they thought she was hypoglycemic. Her HB was about 16.2 with an elevated white cell count of 12,000. Platelets were normal. Sodium was okay, but she had hypokalemia of 2.6 with a normal chloride. But what is surprising is her anion gap was quite elevated. And in that center, we were able to do beta hydroxybutyrate. We can see the reference value there is up to 0.27. Hers was quite elevated. And when they did a blood gas analysis, pH was 7.1. Now, the urea had shown some elevation, a bit of elevation, so there's some acute kidney injury of 14.9 with a creatinine of 130. It would have been good to know whether she had reduced urine output. And her urine ketones were 2+ and glucose was 3+. So again, you're seeing normal sugars, pH is low. There appears to be a raised anion gap, suggesting this is metabolic acidosis with a high anion gap and some degree of AKI. And now we're even finding glucose in urine and ketones. So what is this that's going on? It's not your classic DKA, but she's presenting like a patient who has DKA. And let's talk about another patient, because I need you to understand there are different scenarios. Like this one was not on an SGLT2 inhibitor, but you can see she's presenting with symptoms similar like the first case. Now, what about the third case? An elderly gentleman, 64-year-old, known case of hypertension, had type 2 diabetes for about 12 years and had consumed alcohol for about 5 to 10 years. Now presents the emergency room with left-sided weakness and right-sided facial deviation with slurring of speech. At presentation, he was conscious with stable vital parameters. On CNS examination, he had Broca's aphasia, meaning he can understand what was going on, but he cannot be able to verbalize. He had a 7th cranial nerve upper motor neuron lesion, and he had upgoing plantar reflexes on the left side. The power on the left side, the left upper limb and lower limb. For the upper limb, it was 3/5, lower limb was 4/5. So we start thinking, has he had a stroke? And this was confirmed with a non-contrast CT head, which showed an infarct over the right hemisphere, mainly the temporoparietal area. And he was diagnosed with a right-sided ischemic stroke with the 7th cranial nerve upper motor neuron type of lesion. So admitted to the medical ward. His previous medications, he had been on Ramipril 5 milligrams, a calcium channel blocker amlodipine 5, metformin 500, a DPP-4 sitagliptin, had been added empagliflozin 10 milligrams once a day, and was also on Lantus 10 international units subcut once a day. And then because of the stroke, surprisingly had been put on aspirin 75, but a statin, atorvastatin at only 10, which of course we adjusted accordingly. Now of note was his white cell count was 15, but you notice the neutral, and that's why sometimes when you're interpreting this, it's always good to look at the differentials, because it doesn't necessarily mean an elevated white cell count is because of infection. Hemoglobin was okay at 14.8. Platelet count was normal at 213. A slight elevation of the urea at 14, but creatinine at 88. So it means it's likely an element of just dehydration. In terms of the electrolytes, sodium and potassium were fine. Remember, there was a history of alcohol, so LFTs were done, and your ALT, AST were actually normal. It would have been good to see the gamma GT. INR was fine, but you can see his HbA1c was 13.9%. In someone who's had diabetes for more than 10 years, we're clearly not doing well. And surprisingly, sugars are normal. So it begs the problem, like, why is he confused? Why is he lethargic? Why is he dehydrated? And when we went further, we found he had a pH of also 7.1, and his bicarbs were actually 10. And here, when you do the BGA, the bicarbs ideally should be between 22 to 26. So again, they're presenting some type 1, some type 2. The common denominator is they're diabetic. They are on, some are on SGLT2 inhibitors. One wasn't, there was an insulin pump, but they're almost presenting similar, like they have DK, but not quite falling into that category. And then you have another patient, 25-year-old female, diagnosed with type 1 10 years ago, on the regular treatment with insulin glargine at night, and then the short-acting insulin aspart at a sliding scale as needed before the meals. Now comes this time with complaints of burning sensation while passing urine, high-grade intermittent fever of up to 38 degrees, associated with chills and rigors. And she had complained of nausea about 12 hours prior. So she's not been feeding well, we understand there's a likely aspect of dehydration, which was confirmed on physical exam. She had, her mucous membranes were dry, suprapubic tenderness. Although there was no renal angle tenderness, the rest of the exam was normal. When you look at it now, this time you find white cell count is elevated at 17,000. Platelets are fine. I didn't write all the values because there's quite a lot to cover. Electrolytes were okay, but again, you can see she has a high anion gap at 26, and then some mild elevation of the urea, which we think was mainly dehydration, with a creatinine at 139. But remember, she's had diabetes for close to 10 years, so it begs the question, what else is going on? pH is low, 7.1, with the urine ketones being 3+ and glucose of 3+. Of note was her bicarb was also low at 10. So that's telling you a high anion gap metabolic acidosis. And when we looked at the urine, her white cell, the amount of white cells were 50 per high power field, and nitrites were positive. So we're looking at a UTI in a patient with type 1. Her random blood sugar was actually not elevated. It was about 12. So the question is, what is going on with these patients? Are you just going to treat her as a case of UTI? Is that the one that's contributing to her lethargy and some degree of confusion? And finally, 75-year-old with a 15-year history of type 2 diabetes, had poor control with oral hypoglycemic agents, and she was on metformin and mixed insulin, which is what majority of our patients are, 15 units twice a day, had a positive family history of type 2 diabetes, and then recently diagnosed to have a cerebrovascular accident and was discharged on empagliflozin, aspirin, and atorvastatin about 12 days before her acute presentation to casualty. Why is she brought? Because she has decreased level of consciousness, decreased oral intake for 2 days. So you can see the common denominator with all these patients. Sugars are not too bad, but they have lethargy, they have decreased level of consciousness, and of note is they are a bit dehydrated. There are no preceding cardiovascular, respiratory, or GI symptoms. And when we look for any infection in terms of fever, sore throat, cough, headache, chest pain, there was nothing that was standing out, and had denied the history of any chronic abdominal pain, weight loss, any symptoms suggestive of thyroid disease, recent travel, or ischemic heart disease. On examination was afebrile with a tachycardia of 110, a bit tachypneic at 28, with a blood pressure which was stable at 110/89, moderately dehydrated with a dry oral mucosa and poor skin turgor. Chest examination was normal. Other examination findings were remarkable. But look at the blood gas analysis, and we find a pH of 7.12. Bicarbs are low at 12. Electrolytes, sodium and potassium were fine. Glucose, surprisingly, is normal. So how are we having a picture of metabolic acidosis, but our glucose levels are normal? A high anion gap, urine ketones are elevated, and urine glucose is elevated. That tells us there's something definitely going on with all these patients. What is it that they have in common? Their features. When you talk about diabetic ketoacidosis, you know that ideally you need an elevated sugar for the D, ketones, and then the acidosis. So they fit the last two, but then they're not quite fitting that element of elevated sugars. And that's why Monroe had coined this term of euglycemic decay from as early as 1973, yet we've not known. So this is what we know. And I mean, we really don't need to spend time on decay because I'm sure you've had enough talks on that. But it's a life-threatening complication of diabetes, mainly occurs in type 1, but has been found to also occur in type 2 if it's been triggered by any acute illness like infection, trauma, or even an acute coronary syndrome. But the main hallmark for decay is you have to have an elevated plasma glucose of more than 14. And this combined with the metabolic acidosis and ketonemia then gives you the diagnosis of DKA. So what is this euglycemic DKA? It means that you have a normal plasma glucose, or you may have a mild degree of hyperglycemia between 11 to 14. But what stands out is your ketoacidosis with a pH of less than 7.3 and your serum bicarbonate of less than 18. So unless you actually stop to say, you know what, let's look for ketones, just do us, depending on the setup you're in, do a simple urinalysis and find ketonuria and glycosuria in the urine. That should trigger something in you. Do a BGA, you might be surprised. This patient is actually acidotic. This is why some patients are sent home and then they worsen and they come back comatose. It's missed euglycemic DKA. So the absence of hyperglycemia can conceal the underlying DKA, creating a diagnostic dilemma. So remember, you will not see what your brain does not know. And that is why we're having this CME today. So it's been associated with quite a number of things: partial treatment of diabetes, the type of medication you're giving, like SGLT2 inhibitors, carbohydrate food restriction, and alcohol intake. And I'll talk a bit about each of these mechanisms. But like we know, it's just theories that have been postulated. It's not fully known why it occurs. Now, notice its incidence actually ranges from 2.6 to 3.2 of all DKA admissions, but I don't think we're actually picking it and documenting it because we are managing as a simple case of dehydration. So of note is, you will find the common denominator was dehydration in all these patients that I had seen. And although it might not be as marked in the regular DKA, it is actually present. Your patients won't come with polyuria or polydipsia. What they will present with predominantly is the malaise, the anorexia, and tachypnea. And all this is because of the ketonemia and accompanying ketoacidosis, which will explain why it happens. So one, you have very high index of suspicion. And that's why you need to start thinking every diabetic patient who's coming lethargic, sugar, it appears to be elevated, but not too much. It's just below 14, between 11 and 14. And the lethargic, think, do I need to do my ketones? Can I do a BJ, especially in Kenyatta where it's available? So like I had said, it was first coined by Munro et al., and that was mainly seen in type 1 diabetics. But now with the advent of SGLT2 inhibitors, what I found is, you know, when there's a new kid on the block, we are so excited that we prescribe it. And that's why now we are getting to have enough data about what is really going on. So what causes this euglycemic decay? The concept is you need ketone bodies. And what is happening is predominantly you either have a fasting state or the patient is dehydrated. And so because of that, you have decreased hepatic production and urine excretion of glucose by an one who had infection. Because of the infection, she's probably not drinking much water, she's not eating well, and remember, if she's on an insulin pump, she's still continuing insulin. What happens is, ideally use up most of your glycogen stored. When the insulin is not available, because insulin production is only stimulated when you find that you're in a state where you're actually hyperglycemic, then insulin is not stimulated to be produced. If insulin is actually not being produced, then the body has to look for an alternative source of fuel to be able to get energy. And what is that? That's usually now going to the fats, and breakdown of the fats is what contributes to development of the ketone bodies. So whenever you're not having any insulin production, that is when you have lipolysis and fatty acid production leading to your ketone bodies. So what is this that is causing these ketone bodies to be produced? Patients who, like now you've heard of famous keto diet, the fasting or starvation. When you've told regular patients, diabetic, starve for 12 hours before you go to think, have you stopped to think about what are the implications of not giving this patient any medication and they're also not eating? Can they be tipped into decay? Because you're not having any insulin production because according to the body, once there's hyperglycemia, there's no need for insulin production. There's no insulin production, then you have lipolysis happening, and that's where you have the fatty acid breakdown and excess ketone bodies being produced. Similar with pregnancy and pancreatitis, but I'll go into detail in all of these conditions as we go along. Same with vomiting, and that causes dehydration. And then also your insulin pump, if the patient has not been educated well and they have not realized the pump is not well and it's not delivering insulin,
Apologies, something just happened. We're waiting for Dr. Ngogi to be able to join in again. But in the meantime, please feel free to post your questions on the Q&A. I just had to mute the chat box because it was interfering with the screen for some of the audience. So kindly, please remember to
Can you hear me now?
Yes. Welcome back, Dr. Ari.
Sorry, I think it's just internet.
It's okay. Technology, we expect.
Just finished what you were saying, then carry on.
Fine, I was just advocating for people to post their questions.
Okay, thanks, Doc. Sorry about that. Yes, so I remember all of last year we kept going on and on about SGLT2 inhibitors, and everyone was prescribed these SGLT2 inhibitors because the cardiologists were excited, the nephrologists were excited. But what we were worried about was the newly diagnosed young patients between the ages of, some of them may be undiagnosed latent autoimmune diabetes of patients, LADA, and this can actually be triggered to have decay if they use SGLT2 inhibitors, which we'll discuss. So when we're talking about euglycemia in a patient with decay, it's either a concept of you've got decreased caloric intake, so you're maintaining your low levels of your glucose, and that's why insulin is not produced, and so you have lipolysis and free fatty acid production. Remember, insulin plays a very big role in reducing your lipolysis. So when it's not there, your body has to find an alternative source to produce energy, and that is where you use the fats. And once there's free fatty acid production, you get your ketone bodies. With your pancreatitis, remember, most often times it's induced by alcohol, and in such instances, patient has low calorie intake with the dehydration that then triggers ketone body production. In terms of your glycogen storage diseases, it's actually quite rare, but the one I want to focus on particularly is the SGLT2, because that is where we started finding quite a number of our patients coming with the euglycemic decay. What essentially happens? So you have your SGLT2 inhibitor, and its function, you know, you have a sodium glucose-like transporter 2, which is in the nephron, the proximal tubule. Now the concept is, please tell me when I lose you so that I can make sure my connection is good. Now
you're fine.
Try and reduce your glucose by glucosuria, because they actually inhibit that transporter which allows for reabsorption of glucose back into the body. Now, when you have increased glucosuria, there's also decreased sodium reabsorption. What does it mean? It's perceived in the body that there's reduced glucose. So essentially, you don't need insulin. So continues to eat and decreased insulin production simply because it's being passed out in the urine. So what essentially do? There's enhanced glucagon production. So that starts to raise your sugars. And because there's decreased insulin, there's decreased lipolysis because it's looking for an alternative source of fuel, which is your fats. Once this is broken down, it causes ketogenesis. Once you have ketone body production, now you're starting to increase your ketone in the body. And that is why in as much as you keep passing out the glucose in urine and you have decreased serum glucose, you have ketone body production, and that is how they are presenting with euglycemic DKA. They have the ketones, which is going to contribute to the metabolic acidosis, and your sugars are normal. So what can be tipping these patients? I mean, we have so many patients on SGLT2 inhibitors. It doesn't mean that the drug is bad. It just means you need to be careful and tell them, if you're on medications, there are certain things we need to talk about. Now, why does infection trigger it? Because with infection, it creates a state of insulin resistance. And when that happens, you have increased production of your counter-regulatory hormones, which try to raise your sugars. Once you have increased peripheral glucose utilization, then you know that at the end of the day, there'll be less insulin required. And also because of the infection, you have decreased intake. So your requirement is more, but because your counter-regulatory hormones are producing even more glucose, but you have less insulin, that can tip you. And remember, decreased intake here also contributes to dehydration, which further worsens the metabolic acidosis. A lot of our patients are on SGLT2 inhibitors. You know, I've seen patients who have MIs, they're going for an elective, they were stabilized with medical management, put on the SGLT2 inhibitors because we have robust studies that are showing it's useful. But the problem was the drugs were not stopped with 48 to 72 hours before. So after theater is when you find they're a bit lethargic, they're drowsy. You do a blood gas, they are found to be acidotic, and it's because you push them into a fasting state. So the glucose levels went low. So naturally, production is not there. And again, you have ketone bodies produced. So simple things like when to stop medications pre-op is very important. Fasting, the same concept, like what we are doing is when we the nutritionist had advocated for intermittent fasting with the ketone diet. What it was doing was depleting your glycogen stores, okay? And imagine someone with who is on SGLT2 inhibitors, pushing whatever little glucose you have out through the urine. That is a recipe for disaster. And of course, also fasting in type 1 diabetics can cause that. With alcohol, it's a combination of one, you don't eat because you figure your calories. The calories you take from alcohol is actually useless calories. So you have decreased carbohydrate intake. Then you have osmotic diuresis, which contributes to your dehydration. And on top of that, you have increased ketogenesis. And because of that, that is how you end up with your metabolic acidosis. For your acute coronary syndrome, any stressful condition, you always have an increased counter-regulatory hormones like your glucagon, your thyroid hormone, your adrenaline, noradrenaline, and cortisol try to compensate for the stressful state your body is in. And because of that, it can contribute to trying to raise your sugars. But remember, until then, your insulin production is not as markedly raised. And because you have decreased oral intake, ketone body production. When a patient comes to you acutely has trauma, a diabetic patient has not been feeding naturally, you don't feed them, you do try and give them lots of fluids. The same time, because it's a stressful state, you have increased counter-regulatory hormones. So if you don't give them a commensurate amount of dextrose fluid with your insulin, that is how you end up in trouble. Then in as much as diabetologists, we tell you, please do exercise. There's a reason why we tell you 30 minutes and not more than that. And that is because when you have prolonged physical activity, you now are depleting your glycogen stores. You're not taking in excess carbohydrates to meet the demand of these working muscles. So your body goes into a stressful state. So you have increased counter-regulatory hormones. So that is after they've done like a period of 1 hour, all of a sudden the patient collapses and you wonder why. That is because you had low levels of glucose that didn't stimulate any insulin production to try and control for any high sugars. So your counter-regulatory hormones have to come in to try and raise your sugars. They're not as effective as your glucagon. So by the time it does that, ketone bodies are produced, and that's how even sometimes you get your muscle spasms. because of that. So having said that, and you understand now how we've managed to get euglycemic DKA, then treatment is a no-brainer. Because one, the predominant thing is dehydration, but it's not as much as in the case of your regular diabetic ketoacidosis. So where before we tell you normal saline up to 6 liters, I tell you half. Okay, you don't have to give up to 6 liters. 3 liters is sufficient. But what we say is it's by case basis. So check the level of dehydration. Would you go ahead and give a normal saline? Perhaps not. Like the type 1 diabetic with a sugar of 4.1, that is not ideal. So what we normally do is we would give you dextrose. So ideally, if you have dextrose normal saline, DNS, that's the best fluid to use. But most government hospitals don't have that. So you can start your 10% dextrose as you start your insulin dose. Now, before you go to insulin, of course, you have to check your electrolytes because you have to supplement. As long as your insulin is on board, it push whatever glucose into the cell and with it potassium. And that's why after you resuscitate with fluid, you check your electrolytes and decide if you're going to supplement. Then you start your insulin infusion. Now in DKA, we'd start at 0.1 unit per kg. But here we advocate for half the dose, 0.05, because the concept is you tell the body what was deficient was insulin. And because insulin was not pushing glucose into the cells, introduce the insulin. If you don't introduce insulin, no amount of fluid is going to reverse this DKA. That's something I always stress to my students. Give them the dextrose. The dextrose cannot enter into the relevant cells without insulin. So give them dextrose to push the glucose into the cells. Once the body perceives that now it has the main source of fuel, which is glucose, then your ketone body production is stopped. And that is why the key main things are the fluids, potassium supplementation, then insulin. We don't find a role for bicarbonate, even if your pH is 7 and below, because as long as you hydrate the patient, the only way you get rid of the acidosis is you stop further ketone body production, and that is with the use of insulin and dextrose. Because you're monitoring hourly the glucose and the electrolytes, please ideally do it in a setup in the ICU or HDU. And of course, at the end of the day, you want to figure out the etiology. If it was because of the SGLT2 inhibitors, please stop them, okay? I'm not saying you stop them and never introduce them, but one of the things I think we forget is that, remember the SGLT2 inhibitors, we always tell the patient, drink plenty of fluid, and that's something we forget. An elderly patient, 75-year-old, he has heart failure, probably had an MI or a stroke. You won't tell them to drink lots of fluid, especially if he has BPH, because of the history of running to the loo. But then, is that a patient you want to give an SGLT2 inhibitor if they'll not be able to maintain their hydration status? So those are the things we would need to think of. Your patient is going to theater, has been on SGLT2 inhibitors, please stop them 48 to 72 hours before. So in summary, what I talked about, we know about the regular DKA because it's pretty straightforward. It's something we know and have managed repeatedly. Where here you have metabolic acidosis, hyperglycemia, and ketonemia. The main precipitating factors are things you've always known. Similar with euglycemic DKA, infection, surgery, fasting, excessive alcohol intake, any vascular events like a stroke or an MI, trauma, and prolonged exercise. And the complaints will actually be similar: nausea, vomiting, malaise, fatigue. And management is the same: fluid, potassium supplementation, and insulin. But with euglycemic DKA, it's not as rare as we think. It's because we don't know about it. And that is why we are happy to do such CMEs to educate you further. Diagnosis is challenging, and that's why we are always available for consultation. When something doesn't make sense, always consult. So It should be considered as a differential diagnosis whenever any patient with diabetes presents with an increased anion gap metabolic acidosis, and you've ruled out other things like salicylate toxicity, they are quite dehydrated, or they missed their doses. And the underlying etiology should always be looked for and treated. Always educate before you start these SGLT2 inhibitors. The only people I have a problem with, give your patients, and you can see the current guidelines tell you, if your patient has heart failure or CKD, please give them an SGLT2 inhibitor. It's been shown to retard its progression and actually improve, and even help moving from stage 4 to stage 2 or stage 1. Anyone who's had any cardiovascular event, SGLT2 is your drug. But educate them on, if they start to feel lethargic, they're starting to get confused, they're quite dehydrated, they have not been drinking adequate water, and they're starting to get confused, please come to hospital. And remember when to stop the medication. Any elective surgery, 48 hours before. You can always use insulin during the peri-op and intra-op and post-op period. And when the patient is stable, then restart the SGLT2 drug. Just because someone has had euglycemic decay is not an indication to stop it completely. Where I have a problem is in the ladder. If someone has ever had a case of euglycemic decay in a patient who you are not too sure, you've given them orals, it's difficult to control, the HbA1cs are just rising, think, could this be a type 1 patient? And consider doing your antibodies. If you can't, put them on insulin. Stop that SGLT2 inhibitor. And these are just some of the studies. I'd like you to go case series of patients who developed euglycemic DKA, which were only discovered later on when someone decided to either do your serum ketones or your urine ketones, and just something as simple as a urinalysis can actually save this patient. And you'd be surprised how easy it is. A patient can actually be reversed into normal glycemia without ketoacidosis within 12 to 24 hours. And with that, I am done.
Wow, thank you. Thank you very much, Dr. Ngugi. That was refreshing. I love your approach on doing it on case studies. And your summary is a huge summary. It makes it even difficult for people to ask questions. However, we do have questions that are coming up. And before we start, so euglycemic DKA in your presentation is as old as 49 years old. It was discovered by Mondru. It was coined by them, and diabetes is even older, by 3,000. It's like 3,000 plus years. So my question is, why call it euglycemic DKA? Why not DKA and then have types of DKA? Because somehow we are wired to say DKA is hyperglycemia, ketonemia. Why not that approach? I think because it should be called DKA, and we should just be taught to figure it out, just because you have but anyway, I don't know, but maybe there are answers to that, or maybe there's a reason why it's not asked, and maybe you can enlighten us.
Maybe, I don't know, maybe if I have documented enough cases, then I have the right or given able to rename it to EKA. But you see, the thing is, if you said just euglycemic ketoacidosis, it can work. But then because DKA was already termed a while ago, and the concept was, one, it was occurring in a diabetic patient. Then number two, the fact that you had elevated sugars, and then that led us to believe that if they came confused or comatose and they had ketones in the urine, or you check the serum ketones, and then when you went ahead and looked at the bicarbonates and the pH in the BGA, it was found to be DKA. I think that's when it was initially termed. Let me tell you realistically, even if it was coined in 1973, I can tell you for a fact, It has only come into the forefront now when we're using these newer agents, the SGLT2 inhibitors, because we started to see quite a number of our patients. And that was because we had not studied this drug carefully, and we kept prescribing it to quite a number of the patients, and not realizing that there was something not quite well. We had started the medication, they're doing well, patients are happy, they're losing weight, they're controlling our sugars, but not very well. If you think about it in the grand scheme of things, this is not a drug you want to give with HbA1cs of 12. Because realistically, it only has the HbA1c between 0.5 to 0.8. But because of its other attendant effects, its ability to be very good when the natriuresis, its ability to help in heart failure and CKD, that's where it's become very popular. And so when you have a large number of people, that's when you start to now, it's like a post-marketing surveillance where we are finding that now this euglycemic decay has come into the fore. But maybe we might actually change it to EK, but I still
you
think
never know. I'm
euglycemic
challenging.
decay has
Yeah,
EK.
but eventually
Let's
yeah.
try. Yeah.
But it's actually known as euglycemic decay. That's the term. So
Yes.
to break it down, especially in a public setting, the only tools we can have, other than of course in addition to our high index of suspicion, is BGA, serum ketones, and you mentioned about urinalysis. So realistically speaking, Daktari, I think we all know BGAs and serum ketones, actually serum ketones even in private facilities, sadly, it's very hard to find because it's quite simple, but getting it is one of the things that it boggles my mind. But nonetheless, how do we make sure that people have the gadgets? And I love how you said about urinalysis. Somebody's coming with those symptoms and their diabetes. How many pluses do you need to have in your urine, not to confuse it with dehydration?
So the thing is this, by the time you're having, first look and see, are you having glucose in urine? That starts to tell you that there could be a problem. One of the interesting things is because SGLT2 inhibitors gives you glucosuria, doctors always panic when they see glucosuria of 3+, but someone is having a sugar of 9. And I tell them, don't panic, because that, if you're not getting, one way of knowing if someone is compliant to the medication, do a urinalysis and see if there's no glucose in urine, the patient is not taking your SGLT2 inhibitor. But when you go ahead and you find ketones of 3+ and above, that tells you now we are starting to run into problems. When you get 1 or 2+, that is really dehydration. And you also check, nothing is cast in stone. Always look at the patient in front of you and see what is the level of dehydration. If you're finding 1 or 2 and the patient has dry mucous membranes, you can find the skin pitch takes some time. Even speaking is a problem, because now the mouth is quite dry. That tells you this is likely just dehydration. When you're having urine glucose 3+, ketones 3+, start to think, and the sugars are just 10, 11, and the patient is now starting to become increasingly drowsy, and they're extremely tired, then we know that there's a problem. Like one of the questions someone asked was the fluids. You notice in my presentation, I talked about dehydration as one of the commonest things that you experience. Now, the dehydration you get in DKA is quite marked. You require up to 4 to 6 liters, and even for HHS up to 9 liters. But here you only need, like, you just stay a whole day without having drunk water. That can tip you into euglycemic DKA. Because remember, you're not having high sugars, and wherever sugars are, water is sure to follow. So here the issue isn't the fact that the sugars are high. It is just you require a mild level of dehydration for you to be tipped into euglycemic DKA. So I wouldn't even recommend you giving those 6 liters. You will end up giving the patient problems. Just simple maintenance fluids is necessary. You understand? So for your diagnosis, if you're in a public hospital, do a random sugar, any diabetic patient. You can't tell me you don't have test strips if you don't close the hospital.
I know.
Say that like anyway. So do a
Yes.
random blood sugar. Then do a urine. You find glucose, no ketones. And you start to think what else is going on with this patient. Okay? They're on SGLT2 inhibitor, that is fine. But the minute you find glucose and ketones and the patient just drowsy, put them on fluids. Check and see, is this meditation improving? Is the patient starting to feel a bit better? They are not, then just add a low dose. Actually, I use the 0.02 rather than 0.05. I start as low as 2 units per hour. So if you're in a public hospital, what I do is I tell you, on one hand, you put your percent dextrose and you start running that fluid there. On the other hand, you'll get a normal saline 500 ml and you put 2 units per hour. So if you want to run for 6 hours, just put 12 units, calculate the drops and run. If you see that the patient starts to wake up, that tells you for sure this patient was having euglycemic DKA. You already have your answer because the patient already tell you. Yeah, because within 6 to 12 hours, that already tells you the patient is getting better. So you don't have to worry.
Okay. So just to make sure, yes, Daktari, and just to make sure, rather we're digesting it well, we introduce dextrose earlier. That's the difference with DKA management. We introduce dextrose earlier than a normal DKA.
Yes.
Okay. So
in fact, your main fluid is dextrose.
Your main fluid will be dextrose. Okay. So yes, I would go to the Q&A. Fauna is asking, is there a risk for heart failure patients developing euglycemic DKA because of the fluid restriction?
No. Okay, so in such patients, because you have already the issue of the patient is fluid overloaded, so we always end up restricting, and then also the dose. Now you'll notice that, say, if you're giving empagliflozin, the dose should be 10 milligrams and not the higher one of 25. When you're giving a heart failure patient, you always give it at the lowest dose possible for the particular drug. If it's empagliflozin, 10 milligrams, dapagliflozin, 5. No role for going for the higher dose. And what we found is the lower doses are not actually associated with euglycemic decay. The only problem comes in this. You start the patient on diuretics, and then you give them an SGLT2 inhibitor and tell them to come after 3 months. That is where you're going wrong. Because when they come in acute decompensated heart failure, you know that they're fluid overloaded. So fluid is not an issue. But after 2 weeks, you know that the patient, you've probably dried them out. So then that is when you withdraw your diuretics, because we want the diuretic effect of the SGLT2 because it causes natriuresis. And the interesting thing about this SGLT2 inhibitors is it only causes hypotension if you're combining it with the diuretics. And it's reducing mainly the interstitial edema, which was worsening the heart failure. So your heart failure patients will not get euglycemic DKA if you stop the diuretics. It's when you continue high-dose diuretics in the background of SGLT2 inhibitors is where you go wrong. I hope that makes sense.
Yes, Daktari. Sorry. I muted myself and didn't realize. But yes, it does make a lot of sense. And now we've talked about how to diagnose the patients. There are some questions on symptoms, and one of them is on why does euglycemic DKA present with abdominal pain? Do they present, and why do they present?
So it's the same thing even with the regular DKA, and the concept is because of the marked dehydration. So what happens is even with the regular DKA, you've got hyperglycemia. Once you have hyperglycemia in the background of insulin deficiency, you get the ketoacid. The ketoacids actually cause spasms of your abdominal muscles. And that is why you find as you start hydrating and give your insulin, the patient actually tends to improve. It's because of the keto acids. Once you correct your keto acids, the abdominal pain tends to subside.
Okay, that's interesting. I haven't seen any question on pregnancy, but I would really like to expand on that. You mentioned pregnancy
Yes.
is a risk, but I would like to hear
Yes.
more about the prognosis and how is euglycemic DKA? Is it worse in pregnancy, or is it something that you need to be really key on? Dr.
Thank
Ngugi?
you for that excellent question. So, yeah, you know, euglycemic decay is such a large topic. I think we need to do it again and again. So, like in pregnancy, common in the type 1 diabetic patients who are non-diabetic, they've been taking the regular insulin, and then supposing at that point in time, she either missed a dose or they have this problem that I find most pregnant women go through. Because you have frequency, and that is related to the fact that the pregnancy is compressing the bladder, ladies tend to stop drinking as much water to try and reduce their trips to the washroom. So you can already see we are going into dehydration while she's still continuing to take her insulin. And because they find whenever you eat, you also require to take water, you even find if someone has hyperemesis or just the nausea related to pregnancy, they stop eating. So it's a combination of low caloric intake with the dehydration while you're still having to take the insulin because you are naturally diabetic. So in such instance, that can be a recipe for disaster. But what we've noted is because by the time a pregnant woman starts presenting with lethargy, they start to hydrate. That actually helps them. That's one. And then number two, they're very keen on the sugar control. You know, we are very strict with our targets that for a pregnant woman, we want the fastings to be 4 to 5. And then after meals, it should be maximum of about 7. So the tighter you are with your control, the fact that you still keep on injecting your insulin, however low the dose is, even if you have taken a small meal, that actually prevents them from getting into euglycemic decay. But it can happen, especially if they have an infection. So the reason why your doctors keep doing urinalysis is because, one, they want to rule out infection, because you can never tell with their polyuria what is infection and what is actually normal, or what is called physiologic in pregnancy. When it does occur, it's quite severe, but it's not very common. I've actually treated only 2 cases, and that was because she had used her insulin, her sugars were about 6, but yet we found when they did a urinalysis, she had glucose and ketones. So what we quickly did was put on a dextrose drip and started an insulin infusion, and within 6 to 8 hours, she was actually stable. But in such instances, it's because the patient had hyperemesis gravidarum. So the people who we are on the lookout are patients who have recurrent urine infections, those who are poorly controlled, and then those ones who have hyperemesis. Those are the ones who are actually at risk of getting euglycemic DKA. I hope I've answered.
Yeah, Dr. You've not just answered, but you've actually, if you're open, we also have a session on euglycemic decay in pregnancy, so that it can answer a lot of questions regarding on that specific topic. Then other questions, I'm just combining questions, is we have non-specific symptoms when it comes to DKA. And especially in a resource limited setting, where there are a lot of patients who have stroke, CVAs in hypertension and diabetes, and they're on medications which have more or less such symptoms, those non-specific symptoms of malaise and anorexia and what have you, and there's no BGA and the RBS is normal. Then you do the urinalysis, it comes back. But now, Daktari, I think it's something we know during our training. Urinalysis ketone cannot be the biggest indicator of your ketone status at that particular point. Blood serum ketone is more accurate than urine. It takes about roughly, I think, 3 days, if my memory is correct. So how do you go even up to 5?
7 days.
Wow. Okay,
They're talking about ketones.
Yes,
Remember,
yes.
let me go back to a bit of the science, the biology. Remember that
Yes.
the ketones were 3: acetone, acetoacetate, and beta hydroxybutyrate. So this acetone and acetoacetate are the ones that are broken down to beta hydroxybutyrate. And then now this is the one that is eventually passed out. Now the thing is, because you have ketones that keep on being broken down to the final product, they can go on being broken down for even up to 7 days. And that is why it is not, we don't like using urine ketones for follow-up. You can use your urine ketones to make a diagnosis. But for you to say someone is out of DKA, we don't advocate for it. In fact, most of the patients that I see in the hospitals, I tell them, if you can't afford a serum ketone, don't bother doing a repeat urine ketone after the first one. Look at your patient. What was the patient presenting with? Lethargy, confusion, they are not feeding. If after 24 hours your patient is starting to feed, the patient is feeling physically better, your sugars are better controlled, we are out of DKA. Don't waste your patient's money doing repeat urinalysis and looking to see. In some instances, when patients are a bit anxious, then what we do is we say, if you had say a ketone of 4+, and you repeat a night is 2+, you're out of DKA. But honestly, that is just what we use on the ground, but there's no science behind it to say that if you actually say it is 2+, now you're out of DKA. What if they had just 2+ to begin with? So usually I say is, if you are in a resource limited setting, your patient is still lethargic, think, could this patient still be in DKA and perhaps give insulin at a regular dose? And that's why I say there's no harm in switching your mixage to a soluble insulin. Let it run for 6 hours in fluids. As you run some fluids for 12 hours and reassess that patient after 6 hours, you'd be surprised at what you'd actually find. This patient just packs up and says, in fact, I want food and now I'm feeling better. And it was simply because you got rid of the ketones. The concept is this: ketones are an alternative source of fuel when glucose is not available. Glucose cannot enter the cell without insulin. So even if you give them as much fluid as you want, without insulin, you will never get your patient out of ketoacidosis. That's the concept.
And it's actually a very, very, smart approach towards the concept. The other question is, I have to ask you, Dr. this. So still in some places, people are still doing, the 10 IM and the 10 subcut and the 10 IV insulin, and it's a guideline which I know it's a guideline that has been stopped for several years now. So talk about that a little bit, because it's actually one of the biggest medical errors we have on DKA, and you need to address that question. Over to you.
Yeah, it breaks my heart when I hear people saying 10 IV, 10 IM. And I mean, even when I teach at Thika level 5, when I see that, I feel like crying, but then I go and just educate people. You see, the concept was in DKA that you have hyperglycemia, you want to rapidly bring down the glucose, but then that was where we went all wrong. When you give 10 IV and 10 IM, the concept is we're going to rapidly lower that sugar, right? But what happens is that the body then produces counter-regulatory hormones, your glucagon, your cortisol, your thyroid hormone, your adrenaline, because suddenly you've gone from very high to very low. So that's a stressful state. So your counter-regulatory hormones come back up and now they produce glucose. So you jump right back into having hyperglycemia. But hyperglycemia is not the problem. Ketones, the keto acids are the problem in DKA. the thing that is causing you to have reduced level of consciousness is not the hyperglycemia, it is the keto acids. And the only way you can be able to reverse these keto acids is with insulin, but not rapidly, because you have to tell the body you produced keto acids as an alternative source of fuel because glucose was not available. So what we'll do is give you the glucose, shunt the glucose to where it belongs, which is inside the cells. So we tell you, start with a basal insulin, like Lantus 10, okay? Because you want it to be there for up to 24 hours. Then we calculate the dose at 0.1 unit per kg per hour. So supposing you weigh 60 kgs, so we do 0.1 times 60, that is 6 units. And we introduce that as an infusion so that it slowly pushes that glucose into the cell. Once the cells realize that we are now trying to maintain the regular homeostasis and use glucose, then it goes to the liver and says, we are done. We do not need the fatty acids to be produced, so stop producing fatty acids. As you continue to produce glucose, the keto acids are passed out in the urine, and that is how you get rid of the keto acids and the mentation improves. That is how your pH now starts to go back to normal. Now, if you try and rush it by giving IV and IM, all you do is cause hypoglycemia, then you panic, end up giving them dextrose, they end up getting hyperglycemia. And so those fluctuations between hyper and hypo is what keeps this patient confused and lethargic and in DKA for a longer time. And that is why even as KDSG, we release protocols with Nordisk, which we are going to release now to each of the hospitals, talking about each of these protocols. If you want, we will come to your casualty and teach you one-on-one on how to implement these protocols, because we can't be losing DKAs, we can't be losing patients to DKA, and it's something that is so simple and very easy to manage. Remember, in DKA, the problem is you're dehydrated, you have hyperglycemia, you have keto acids. Hydrate the patient, make sure you have sorted out electrolytes, start your insulin infusion, and you're home and dry. By the time you're getting to sugars of 14, then you're starting to change your type of fluid to dextrose, and you're reducing your dose of insulin by half. There is no excuse in this country that if you don't have an insulin infusion pump, you can't manage decay. I manage decay every single day, and all I do is just put it in. It's not a the in an infusion line and then calculate the drops. And the nurses are very good with that. The first people we talk to are actually the nurses, because who teach us how to calculate the drops. That infusion to run over 6 hours, then go back and see how are we going, what are we to do after the 6 hours.
Dr. I'm not sure if it's just me, but I cannot hear you. Dr. Ngugi? No, Nelson, is it just me?
Come again, Doc.
Yeah, Dr. Ngugi is definitely having a bit of technical challenges. So there's a lot of questions on repeating some of the concepts. I'll try my best to repeat them, but in case you missed it and you want to listen, you can go to our YouTube channel. It's KNH Research, so that you can be able to listen. We'll try and upload this as early as this week, so that you can be able to listen in and get what you missed. Please don't hesitate to subscribe as well, and give us your inputs on how we can make your experience on the KNH-UoN webinar much more relatable and much more engageable. And she is back. Dr. Are you back? But in summary, I think the last question she was talking about the 10 IM and 10 IV. In summary, please let's stop doing the 10 IM, 10 IV. It's not recommended. In fact, it is very detrimental, especially if you don't know somebody's potassium levels. It's the worst thing you can ever do because insulin actually dips it down. And one of the biggest reasons why you'd even have an early mortality in a DKA patients is if you introduce insulin before knowing the potassium levels. So, Doc, are you back?
Yes, I'm so sorry. I haven't tried another. This is very embarrassing.
No. Imagine it's not. We are easy, and I hope the audience will be easy too. So, you were discussing about the 10 IM, 10 IV, and I also
Yes.
wanted to ask. I wanted to ask because it's really important. You say in euglycemic DKA, the sugars are normal, right? You have
Yes.
9, you have 10, you probably have 12, right? The highest. But
Yes.
you still mentioned about giving insulin as an infusion. I'd like you to break that up because it's a bit confusing when you have, like, why am I giving insulin, and the insulin is normal. Kindly clarify why that is important.
Okay, even as I've seen that, I can see someone was even asking the dosage for soluble insulin infusion. Now in DKA, because there's hyperglycemia, it is 0.1 unit per kg per hour. But in euglycemic DKA, the dosage is 0.02 to 0.05, basically half of what you would ideally give unless you're having DKA itself. In euglycemia, remember the sugars are normal. So if you go ahead and actually give at 0.1 unit, you will cause hypoglycemia. Now the concept is this, that the ketone bodies were produced because the body felt that glucose was not available to be used as a source of energy. Why? In instances where the patient was fasting, did not take any carbs, patient was starving, patient was dehydrated, patient was on insulin, but the patient was not feeding, okay? Or like in SGLT2 inhibitors, and that one is where it is very common because I've seen even another question with that. So I'm combining all the questions together. Remember this now, let me take you down this story very well. So in SGLT2 inhibitors, how they work is this. Whenever you have glucose and your body is trying and calibrate and make sure that it is normal, ideally some glucose is passed out through the kidney. But in the proximal tubules, there's an sodium glucose-like transporter 2 receptor, SGLT2. Now, what its work is that anytime a sugar comes to the proximal tubule of the nephron, it's supposed to reabsorb this glucose and go back to the body so that it can be used for energy. Now, what these inhibitors do is that they block this receptor. So how they lower sugar is by passing excess glucose in urine. Now, if your body perceives that there is no glucose in the body, okay, then how insulin is produced is in one way. Whenever you have a high glucose, what happens is the body stimulates the beta cells of the pancreas to produce insulin. So insulin will only ever be produced when you have high glucose levels. So in these instances where I was giving you scenarios, glucose levels were not elevated. And so because of that, there was no need for the body to produce insulin. Now, for glucose to enter into the cell, what does it require? Insulin. All these other scenarios we gave you, the glucose levels were normal. So will your body produce insulin? It won't. So in such instances, for the body to start using glucose, you have normal glucose levels, they're available, you have to give insulin in an infusion. Why can't you give it as an injection, subcut or IM? Because one, the patient is dehydrated. So the intravascular compartment is actually collapsed. If you give it through the muscle, it can rapidly cause, because muscles have a very rich blood supply, that insulin, when it's injected IM, will find that the glucose drops rapidly. And so, and you don't want the patient to get into hypoglycemia, because then you won't know, is the patient confused because of ketones or hypoglycemia? So the gentlest and most effective way is given insulin infusion. And now, because we don't want the sugars to go too low, the doctor should not panic. Then what you do is you put your 10% dextrose on one end, and on the other end, you start your insulin infusion, so that as you push glucose into the cell to tell the body, start using glucose as energy, it's also telling the liver, stop producing fatty acids to help with making ketones. So I don't know if that helps. That is why you need the insulin infusion. Don't give IV or IM, because in IV, remember, intravascular compartment has collapsed. IM, the muscles have a very rich blood supply. You'll end up going straight into hypoglycemia. Then now you start chasing your tail of trying to give dextrose.
Yeah, Kabisa. So, sorry, another very, very interesting question is, and you had brought that out very clearly in your case studies when the white cell counts were high, and
Yes.
but neutrophils and everything was normal. Mary is asking, how does infection cause both euglycemic and hyperglycemic DKA, and why would one suffer a euglycemic type whilst another hyperglycemic type of DKA?
So in such scenarios, you have two scenarios. One is a patient type 1 or type 2, and then are they compliant? So a patient who has who develops DKA, the concept is whenever you have any infection, that is a stress response. Whenever you have your body gets stressed, then your counter-regulatory hormones are produced to try and deal with the stressful situation. And that's when you get thyroid hormone, adrenaline, glucagon, and all these other growth hormone being produced to try and control the stress by raising the sugars. When that happens, that is how you get hyperglycemia. And in such a scenario, supposing you're type 1 and you have not compensated for the raised sugar by raising your insulin dose, then your body perceives it as a relative insulinopenia, and that's when it starts using fatty acids as a source of energy. And once the fatty acids are produced, then you end up getting ketoacids, and that is the regular DKA. In a patient who gets euglycemic DKA, infection is the one that tipped them. Like, let me give you the scenario of the type 1 who was on the insulin pump, then didn't realize that the insulin pump was malfunctioning. She was still injecting herself the regular insulin. So your insulin caters for the hyperglycemia and controls it and brings it back to normal glycemia. Okay? But then your body is saying, we don't need to take even a higher dose simply because we already have enough insulin. But in that same scenario, when you have infection, like she did have a UTI, in this scenario, the starvation, she's not feeding and she is dehydrated, then these are the other factors that come into play that then now further stimulate the production of ketoacids. It's not the insulinopenia, it is literally because of the starvation and the dehydration with the low caloric intake that then now gives you a scenario of euglycemic DKA. So in any patient, whether you're diabetic, I suspect majority of our patients begin as euglycemic DKA, and they try and manage it at home until the point where they're unable to, and that's how they end up with DKA. So, and that's why the first thing when we talk about the sick day rules, whenever a patient is unwell, one of the things we'll tell you when we'll be producing this ebooks on outpatient care of patients and inpatient care for patients with diabetes and its complications. One of the sick day rules is when a patient is unwell, do your sugar, do your ketones. because that is one of the earliest signs of euglycemic decay before they go into hyperglycemia and get into the regular DKA. Have I?
Yes, Dr. You have. There was a question. Sorry, I have to ask this question because I wanted to Google, but I don't even know it. Or Arsala is asking, please talk about Down phenomena and smoggy effect.
Oh, so I think she meant the dawn phenomenon, the dawn, DAWN phenomenon, and the Somogyi effect, and the SOMOGYI effect. Now, those terms were coined when you were trying to understand what was going on with patients. You have patients who have are on insulin, okay? And they inject, say, if you're on basal bolus, where you are talking about 3 times a day pre-meals, the short-acting, and then you have the long-acting Lantus, where you inject. And then at some point in the middle of the night, they get a hypoglycemia, okay? Now, what the body does is, as a counter-regulatory response, it produces hormones which try and raise the sugars. So when you wake up in the morning, you find this patient is having hyperglycemia. And the more you try and raise the dose of your Lantus in the evening, the more it worsens the hyperglycemia. So to try and figure out whether this is the dawn phenomenon, we tell the patient, do a 2 a.m. sugar. If you find that the patient's sugars go to 5 and below, they go to 3 or 4 or 2, then we know it is the 10 p.m. dose, the Lantus, which is too high, and that is what is causing hypoglycemia, and then further contributing to you getting hyperglycemia in the morning. So the only way to pick up these effects of dawn and Somogyi is by doing a 2 a.m. And that is why we came up with, as diabetologists, a 7-point sugar testing. You've heard of doctors writing 7-point sugar. What does it mean? You do before breakfast, 2 hours after breakfast. Before lunch, 2 hours after lunch. Before supper, 2 hours after supper. At 10 p.m. and at 2 a.m. Ideally, it should actually be 8 point. The 2 a.m. is to tell us whether our dose at 10 p.m. is too high or too low. Similar with your Somogyi effect, it is patients who are presenting with hypoglycemia early in the morning, and you're trying to figure out, is it that it's the Lantus dose that is too high, or the patient did not eat? And that's when we realize, for most of the patients who we put on basal bolus, we usually tell them to take a snack with the 10 p.m. so that they don't end up getting hypoglycemia, because this Lantus dose which you inject at 10 p.m. will be in the system all the way until 10 p.m. the next day. So as much as there are fancy names that were given, it was just to figure out why patients were waking up with either a hypoglycemia or hyperglycemia. And we prefer, rather than telling a patient just to do HbA1c, it is monitoring of the sugars. If a patient can't afford to buy as many strips as possible, you tell them, on one day you do before breakfast, 2 hours after breakfast. Another day before lunch, 2 hours after lunch. Another day you do before supper, 2 hours after supper. And another one, if they're waking up with very high sugars, do the 2 a.m. sugars. That will give you the answer.
Okay. Sorry, Dr. Sorry. Regarding pediatrics, in the public sector, especially in Kenyatta, we currently have like 600 beds for pediatrics, and our pediatric definition is actually from 13 and below.
Yes.
I don't know about the other settings, so we're not really taking the pediatric per se. But what is your history in regard to pediatrics?
Okay, one, I don't have history with pediatrics because I specifically say I'm an adult endocrinologist. But the main thing with the children, when it comes to children as opposed to with adults. You see, like with the children, with adults, we'll say 0.1 units per kg per hour. And for the fluids, we'll say 1 liter in 30 minutes, 1 liter in 1 hour, 1 liter in 2 hours, 1 liter in 4 hours. And that is because we've estimated the average adult is 60 to 70 kgs. With a child, you can't afford to do that. You actually have to resuscitate according to the kgs, so that we say initially 20 mLs per kg, then we continue the maintenance dose of 10 mLs per kg. So it's very easy to go into cerebral edema and have fluid overload if you don't calculate the dose of the fluids. And that is why I encourage you to call a pediatric endocrinologist to talk about DK in the pediatric setting, because I remember one of the pediatric endocrinologists saying they would never give an adult the kind of doses we give, like in terms of the fluid, because the fluid deficit is not like the adults, where you need up to 6 liters when it comes to giving fluids. And for us, it's pretty standard that the target is 6 liters in 24 hours. If you have euglycemic decay, it is 3 liters in 24 hours. Remember, in euglycemic decay, the dehydration is just mild, it is not severe. And as for the person who is asking about the insulin infusion, we always put it in normal saline. We don't want it to crystallize. What we do is, the rule of thumb for any DKA patient is 1 hand, you will put the fluid that you want to use for resuscitation to deal with the dehydration. The other one is where you'll put the insulin infusion, and we always put it in normal saline. So like in euglycemic decay, 1 hand will have 10% dextrose. The insulin infusion, if you don't have a pump, will be in normal saline. If you are dealing with decay, then initially you will start with your normal saline on 1 hand, and on the other one, the insulin infusion will be on the in the normal saline as well.
Yeah. Sawa Daktari. So in the interest of time, I don't think we'll be able to address every question. And like I mentioned earlier, kindly just, if you want to listen again to this, you can find it on the YouTube channel and the KNH research platform. So Doc, tell us a little bit more about you, because somebody was asking where we can find you. And the other thing is, I forgot to mention, Daktari is actually one of the officials in Kenya Diabetic Society. So
yes, actually, thank you so
yes.
much. I am the current secretary of Kenya Diabetes Study Group and the secretary for Kenya Association of Physicians Nairobi branch, and the assistant secretary, national office for KAP, and I'm also in the training committee for EXACOP. I love teaching and training. I'm mainly based in Mount Kenya University. I teach, but I have my own private, we say, kiosk that is based in Parklands at 6 Parklands. It's called Status Medical Imaging Solutions, where I'm there all week long. I'm very passionate about training. And so this year we are focused on doing trainings for clinical officers and nursing. In fact, currently we are going to be, from February, launching a course that is just a 6-week online course, just giving you briefs about introduction into diabetes and also how to approach the management. My number I will put in the chat box for anyone who'd like further referrals. I can always be available. You can call me or text me. But yes, I'm very passionate about diabetes. And thank you, Amina, for having me. And I'm very happy to come back again and talk anything about diabetes and endocrinology.
Sorry, thank you, Daktari, so much. So what is your take-home message? Like we've said a lot of things, and sorry, I forget this very important questions that people have been asking. Where can we get the serum? And for any person who has a hospital, owns a hospital, or is in a position whereby they inform policies, I strongly believe that we should have glucometers that are capable of detecting if you have ketones to make it a bit easier and faster to pick DKA and euglycemic DKA. So what are your thoughts there, and what are your parting shots, Daktari, so that we can end the session today?
Yeah, so it's interesting. We have so many glucometers like AccuCheck. I'm not advocating for them as in advertising for them, but one of the glucometers that have the ability to check for both the glucose and ketones is the AccuCheck. And all you have to do, the machine is free. All you have to do is just buy the strips. So we are now we are in a problem because we've had an issue of now the taxation. We had removed tax on the strips and now it is back. So we are hoping that we can be able to lobby for the taxation on the strips to get out, as well as with the insulin. But it would be advisable if you can just advocate for the right glucometer. The AccuCheck, the On-Call Plus all have the glucometers that can check for both the glucose and the ketones. And it is readily available, and it's actually been validated in studies that you can be able to check it. My parting shot is this. Remember, what you don't know, you cannot diagnose. And there is no harm in consulting. When something doesn't ring right, if there's one thing that has taught me in the 15 years of my medical experience, is that whenever you see a patient, all your parameters are okay, they are normal, but the patient is unwell, take a second look. If you still don't get it, ask a senior colleague to assist you, even your assistant who is there, your fellow colleague. You might be surprised by what you're missing. We really would advocate for screening. Euglycemic decay is there. It is killing quite a number of our patients. It was actually missed. So they're not quite what is going on. You may be surprised by how many lives you'll consult. We are readily available. And I will be sending flyers on all the trainings that are coming up. There'll be the KDSG conference, which will be there between the 7th and the 10th of June at Nairobi Hospital Convention Center. See you all there. You're all welcome. There's something for everyone.
Yeah, thank you. Thank you very much, Daktari. Then, so tomorrow, we are going to have our cancer elimination series. January is a month whereby we highlight a lot about what's going on in the cervical cancer space. And the Ministry of Health, in combination with many other partners, KEMRI, KSHO Alliance, and to name but a few, we've come up with 2 sessions for us, and tomorrow we'll discuss mostly the statistics on what's happening in Kenya. Where are we as a country, to continue and to know where we are, what services are available in both public and private sector, and what we can do better. Cervical cancer is a preventable cancer, and it's the second leading cause of cancer in Kenya. So be sure to listen in, because it's the most common cancer we have in the country. And as usual, please look at our YouTube channel and subscribe if possible, and also on our Twitter handle. So thank you very much, guys. I will see you tomorrow. Bye-bye. Thank you, Rosie, for the wonderful
so much
session.
for having me. All right, no problem.
Okay, bye-bye.